Hello and welcome. Thank you for logging in to our BAME Women's Health webinar. The aim of this session is to bring to the forefront health issues which disproportionately affect BAME women. We would like to encourage you to ask any questions, no matter how small, and we will endeavour to provide clear answers. So just a little bit of an introduction. So it is widely accepted that women from a Black, Asian and minority ethnic background are harder to reach and so less likely to access health programmes for various reasons. To understand these barriers requires engagement, understanding and trust from our healthcare services. And this is something we are extremely keen to engage with, hence the reason for our session today. So I would like to take this moment now to introduce you to our panel. I'll introduce myself to you first. My name is Siobhan Cranjanasalt and I work for the Ipswich and Suffolk Council for Racial Equality, so ISCRI. My role is to engage with the BAME community to ensure that their voices are heard at an official and statutory level regarding health inequalities. So firstly, I'd like to introduce you to our panel of speakers. So I'd like to introduce you to Melissa.
Hello, my name's Melissa Took and I work for an organisation called the Suffolk GP Federation. I'm a project manager and for the last 6 months I've been working on a cervical screening project to increase the uptake in Suffolk of women who currently are undertaking screening. So today I'll be talking to you about what we've learnt and what we hope to achieve over the next year. Thank you.
Thank you, Melissa. And next I'd like to introduce you to Helen.
Hello, I'm Helen Bowles. I'm the Maternity Transformation Programme Manager across Suffolk and North East Essex. And my role is to implement the national transformation programme for maternity services to ensure that no matter where a woman lives, that we get consistent outcomes for any woman, no matter where they reside or their ethnicity. Thank you.
Thank you, Helen. And next I would like to introduce you to our GP. So we have on our panel Lolu.
Hello, I'm Lolu. I'm a GP in Ipswich and on the governing body of the Ipswich and East Suffolk CCG, where the areas I help provide input to are include maternity and sexual health, prevention and self-care and social prescribing, and children and young people's mental health. I'm glad to be here today just to answer any questions or to provide more information on any issues that you might have or want to raise.
So thank you to our panel. So firstly, I would like to introduce you to Melissa, who, as she mentioned before, is going to present on cervical screening. And again, if you have any questions, please feel free to pop them into the Q&A box at any time. Okay, over to you then, Melissa.
Hi everybody. I'm going to talk to you today about cervical screening, the importance of it, and talk with you about some of the barriers and the things that stop us from going and having those really important appointments. I personally and the organisation I work for are really passionate about changing inequalities in healthcare and improving the uptake of this really important screening. 20% of women in our county don't have the screening, and we know that a large proportion of those women come from various groups, including the BAME communities. We've been working since October 2020 on this, and we introduced an extended access service across Suffolk to let women have screening appointments during the evenings and weekends to try and help, you know, with making it more convenient. Part of this has also been to learn and understand and speak with community leaders, health organisations and charities to understand what the barriers are and what we can do differently to help. We've been speaking with lots of women across the county and learnt lots of things. So I'm here today to gain more learning from you and also to answer any questions that you may have. By speaking with women so far, what we've learned is that when a lot of women receive their first invitation at 25, they really know nothing about it because there's a real lack of education at early age. Lots of women don't attend screening because fear from past experiences. Maybe they've had a bad experience in this country, or maybe they've had a bad experience in their home country, or in fact, maybe they've had no experience. Embarrassment. Well, we're all embarrassed about that part of our body, showing it to other people, and I get that. But I suppose it's to make it really clear that we always use women, which I hope helps to some point. And we've introduced such things as a buddy system, so you can take a friend along or a chaperone, someone to make you feel more comfortable and safe in that environment. Discrimination is an obvious one, an obvious fear across all sorts of groups. People may have different customs, may feel differently about their body due to their customs, and that can be a huge barrier when it comes to going to the doctors. Childcare is another one. We have families and we find it hard to find the time to go to appointments. So we're hoping the extended access service might help with that. The other thing we've learned is a lot of women actually return to their home country to have their screening. This is particularly concerning because clearly if we go home and then we have a problem, how do we deal with that afterwards? So it's really, really important to have your screening here so that your GP can follow up afterwards if they need to. So when should you have your screening? Screening should be done every 3 years when you're aged 25 to 49 and every 5 years from 50 to 64. We've found that twice as many women have knowledge of what the actual test is to the ethnic groups. We believe this is because of lack of equality at national level, lack of language and understanding those barriers. And we believe we need to change mindsets and educate about the barriers there are within healthcare to this. So what we're going to do now is we're employing a group of what we're going to call health educators to go out and work within the practices with clinical staff and non-clinical, such as the receptionists or care coordinators, and help to educate them and work with them to teach them how to ask those awkward questions. It's been shown that staff often have real discomfort with explaining questions. And what this does is it mirrors to the assumption that you as the patient has discomfort with answering those questions. Staff often project these uncomfortableness onto patients. This can be just down to lack of confidence and unbiased and unconscious bias, but it leads to not understanding the patient's specific needs. Our health professionals are great, and I'm not for a moment suggesting this is across the board, but what we have learned is that we're in a changing world here, a changing country, and that healthcare needs to change with that. So far, we're encouraging language line in all practices. So when we do appointments in the extended service, we're making sure that the practices tell us in advance if language line is needed so we can make sure it's available. We're offering longer appointments to make sure if you need that extra time, it's there for you. Also, we're offering pre-educational appointments over the telephone. So if you're thinking about having your screening but you're not sure, we can offer an appointment to talk to a healthcare professional to talk through exactly what will happen and any concerns you might have. We're also looking at appropriate marketing. So we've been working with community leaders to put out marketing in various languages and use appropriate images. In some communities, imagery that we use at a national level isn't necessarily appropriate and can make people feel really uncomfortable. So we've been working with community leaders to understand that better and to use local faces to promote the service. We're going to form groups and events like this where we can talk to you and understand further what we can do to make change. So this is what we've learned so far. So now I'm really interested to hear your questions and actually hear your advice to how you think we can do things better and we can improve the service moving forward.
I was going to ask our GP Lolu if she had anything to add about that, about especially the experiences when visiting your GP and how they could explain, or individuals could explain their needs to make it more comfortable for them.
So cervical screening is or having a smear test is another way you often hear it described. If you want, if you're nervous about having it done and want to speak to someone about it, or if you want to have a chaperone, for instance, or someone come along with you, when you ring the surgery, if you just mention it to the receptionists, they can have one of the nurses give you a call back and talk you through it if you want. During COVID times, we are still doing smears, although generally trying to reduce traffic in the building. So most people aren't allowed into the building with somebody else accompanying them, just to reduce the amount of traffic in and out of the building. But if you have a special circumstance and you need someone to come with you, it's important that you say when you try and make your appointment, so that that can be taken into consideration. The nurses who do cervical smears have done this lots of times, and they do know, they're used to people being nervous, used to people being, uncomfortable, and they have things that they know they can advise you to do to try and help you be a bit more, to be more relaxed and to make it easier. So the more relaxed you are, the less uncomfortable the smear tends to be. So they're really experienced at that and really good at helping people to feel comfortable and relaxed and calm about it. So it's really important that if you have any concerns at all, that you let us know when you book, or if you want to talk to someone about it in advance, then you can ask for that.
So please phone your surgery, speak to your care coordinator. If you feel that you can't get there during the day, and as Lolu said, it's in the practice it's quite difficult at the moment due to social distancing, you can come to GP Plus, and we operate from Riverside Clinic in Ipswich, also Felixstowe, and we can market at the moment. So you can come to GP Plus, and they are practice nurses. You might not necessarily have met them before, but we are offering that service. And if you do need to bring someone with you, or you need a longer appointment, or you need language line, just let the care coordinator at the surgery know that when you're booking the appointment, and they can feed that through to us, so we can make sure that we can put any adjustments in place for you.
Okay, thanks, Melissa. So now I'd like to introduce you to Helen, who is going to talk about maternity, and I believe she has a slide to go through as well.
Okay, so I'm just going to talk about the maternity transformation programme, and I can pick up one of the comments that was just put in the Q&A section there as we go through. So there is a national transformation programme for maternity services to really ensure that both the women and the newborns receive high quality care, and that we do the absolute best that we possibly can for those families to get a good outcome at the end of their pregnancy. So I'm just going to go through the main elements of that. And again, as Melissa said, if there's any questions, etc., please do put them in the Q&A section, and I'll try and pick them up as I go along or at the end. So if I could just have the next slide, please. So the priorities for the transformation programme are to reduce inequalities and improve the outcomes for all, as I've just said. So the aim is we're working across the whole of Suffolk and North East Essex, and things are done differently within the hospitals, and we're trying to ensure that there's a consistent model of care across the 3 units, so that it doesn't matter whether you live in Newmarket or Jaywick or Central Ipswich, that you will receive the same type of care, level of care to ensure that you have a healthy pregnancy and birth of your choice. So through doing this, we are aiming at having personalised local care, providing families with the information that will help them to make informed decisions about their pregnancy and birth and postnatal care. We are looking at evidence the whole time to ensure that we provide the safest care possible, and looking at different ways of doing things, particularly at a local level, that will benefit our communities. We ensure that the voices of families are listened to and acted upon. We have service user groups, which I'll talk about a little bit later, that are really hardwired into our programme and are the main voice that we listen to when we are thinking about how we can improve our services. The specific work streams around postnatal care and neonatal care that's nationally has been recognised as areas that do need specific targeted actions, and also around mental health services for pregnant women and their partners. So if we could just have the next slide, please, Jen. So personalised care. So what we're trying to implement across the whole country is a new model called continuity of carer, so that you would see the same midwife throughout your pregnancy. They would support you through the birth of your baby and the first 10 days to 6 weeks in your postnatal period. Now, research has been done on this, and by the midwife being with you throughout that journey has a massive positive impact on your birth. So they've shown that by having that relationship with your midwife, that there's a 24% reduction in preterm births. So not so many early babies or small babies that can then have complications. You're 15% less likely to need an epidural for your pain relief and manage with gas and air and some of the more milder types of pain relief. And locally, we've seen also that having that relationship with the midwife, our women are saying that they feel safer during their pregnancy and birth because they've developed a relationship with the midwife. She understands everything about the woman, her pregnancy, her family, her wishes. They develop a relationship, and the trust that she has with that midwife then supports her all the way through. And we've seen, when we've been trying this locally, that also we've noticed a trend of women having a much shorter period of labour, that they give birth slightly quicker because they are more relaxed, because they know the midwife and trust that they will advocate for what their wishes during the childbirth. So alongside that, there will be very small teams of 6 to 8 midwives covering a small geographical area, so that they become part of the community, link with community groups, try and do health promotion activities, link in with baby groups afterwards, so that they're very much part of the community, and families will get to know them as they have more children, as well as sort of a local friendly resource. And it enables us to provide personalised care planning. So we've put in the Mum and Baby app, which all women should be able to access online or on a smartphone, and that gives huge amount of information about any element of pregnancy and childbirth that you can think of, that gives you the information that you can look at yourself and discuss at home, and then talk in a more informed way with your midwife and discuss it. Whereas in the past, so when I had my babies 8 years ago, it was very much I was looking to the professional to tell me what to do, whereas we're trying to help empower people to understand what their choices are, and being able to lead the care themselves alongside their midwife. Sorry, my puppy's barking in the background. And also we're trying to introduce and remind people that there is a choice of where you have your baby and where you receive your care. So just because you live in Ipswich, it doesn't mean you necessarily have to birth at Ipswich. You could have your baby at West Suffolk or Colchester, and also you can have a home birth, we have midwife-led units either alongside the hospital or standalone, as well as the more traditional birthing centre. Okay, next slide, please. So in terms of reducing our inequalities, so we do know that certain communities, people from a more deprived area, or some people from different ethnic minority groups, do have slightly reduced outcomes than other families. So we are trying to ensure that we lift the bar so that it is consistent for anybody, no matter where they live or their background. We've introduced, particularly during the COVID pandemic, we've seen that there is a slightly different presentation from women from Black and Asian communities, and so we've changed the admission criteria and thresholds so that people can access services and be admitted at an earlier stage, so that we can really support the families. The continuity with the midwife is the most way of improving those outcomes and reducing our inequalities, as well as looking at we've got some bespoke materials for different ethnic groups to think about things like vitamin D. It's really important if we cover our skin or if we have a darker skin, to ensure that we have vitamin D supplements during pregnancy, etc. So there's some targeted elements of our programme. We're also implementing some a care bundle around reducing the risk of preterm birth as well, and there's a number of elements of that, including supporting whole families to stop smoking during pregnancy. Next slide, please. So we've been working with our service users to look at how we can communicate with all of our women across the county, and we've started to develop an online resource, which I'll put the link in the Q&A at the end of my talk. And there are a number of resources on there. We've tried to translate all of our information into the most common languages used within our area. We've been trying to make more infographic description of our services and what to expect from them, and access through QR codes as well. Next slide, please. We've set up a resource for our staff as well. So this is called a Padlet. I'm not technical, but apparently it's an online resource hub that you can link onto. So as I say, I'll put that at the chat at the end, and this is where you can access all your information. And then next slide, please, Jen. We've also set up a resource for our staff and engaged with some women from different communities to talk about how they would like to be cared for and things that they would like to be considered, particularly during their care pathway. Next slide, please. So mental health services for the whole family. So we know in the past that you know, people say, oh, you get the baby blues, and whereas now we are much more informed around, and hopefully getting that across to our women around what is normal, around, yes, there will be a dip in your hormones immediately postnatally, but also what the other signs are that you might need to be looking out for in yourself, or for your partners to be looking for you, because we don't always see it ourselves when we're in that cycle of feeding and nappy changes, etc. My GP colleagues are on the call as well, but we've been rolling out some training to help the GPs understand the needs of parents, both the women and partners, during that postnatal period up to a year postnatally. We've set up some very specific specialist services for people who are suffering from mental health conditions related to pregnancy and birth, But also we're working with the charitable sector to look at more accessible support groups in the community through libraries, etc. And also we've commissioned a service called Petals, which is a specialist bereavement service for those people who may have lost a baby, had a very late miscarriage, or had a traumatic birth. And they support the family through that immediate period. And if they go on to have another pregnancy, they also support the family through any worry that they might have during that subsequent pregnancy. Last slide, I think, please. Oh, postnatal and neonatal care. So we are about to develop a new pelvic health service so that we are more proactive with women around any pelvic floor muscle training, any continence issues that may be resulting from childbirth, etc., to try and be very focused on how we support women to prevent as many issues as possible, and if there are issues, how we would support people in a timely manner to resolve those. We're looking at how we can get consistent information between maternity health visiting and GP colleagues. I remember I was very confused because I would talk to a health visitor and she gave me a different recommendation to the midwife. And so we're trying to work across all three areas to ensure that we're giving consistent information, and no matter who you go to, you'll get the same advice. General practice have introduced an 8-week check of mum and baby now, and that's an opportunity for you to discuss any concerns you may have. And we're linking across again with health visiting to ensure that there's no gaps in information so that you don't have to keep repeating your story. I'm just aware of the time, so I'll just move on to the next slide. So families at the centre. So this is absolutely at the centre of what we want to do. So we have maternity voice partnership groups across Suffolk and North East Essex, and there's one within Ipswich and East Suffolk. And they bring the voice of service users. So they have service users on their group. We invite them to meetings. So when we're setting up the new pelvic health service, we will have groups of service users who have experienced that in the past, who can tell us how better to improve our services, what you may want from services, not what we think people might want. And also they know they come in and do safety visits and quality checking and give us feedback on which we act. And they attend our board every month so that they keep us online to make sure that we are listening to those voices properly. And we're about to develop our new strategy, and we'll very much be going out to the public and all of our communities to get feedback and ideas about how we can further improve maternity services. Last slide, please. I think. Oh no, I'm still going. Sorry, everybody. So obviously safety and innovative care is absolutely our highest priority. So there are a number of initiatives that have come out nationally and locally that we're trying to do. We're trying to look at, particularly during the COVID pandemic, how we can be a bit more innovative with our care and ensure that people have equal opportunity that they would have had outside of a pandemic situation.
The first question we've had is there has recently been many papers looking into increased maternal death within the BAME community. Are there specific Black community maternity hubs?
There aren't specific Black maternity hubs. We are very much looking at it, creating hubs around communities. So rather than ethnicity, within that, all of our midwives are aware that there are higher risk for Black and Asian women around maternal death. And within that personalised care that I was talking about, the midwife will be talking to that woman and ensuring that we have a bespoke care plan for her and her needs as an individual.
Okay, so thank you, Helen and Aisha, for that. What we're going to do, we're going to try something. We've been having technical difficulties, so I am going to hold up my phone and have Imani talk into it, and she's going to discuss fibroids with you. So Jen, if we could put up the presentation.
And I work supporting clients, individuals and groups in and around Suffolk, but also nationally as well. My work with women primarily is around womb wellness, really, and fibroids. After 15 years ago, I myself found out I had fibroids, and I went on a journey to qualify around holistic health practice to shrink my own fibroids, because I didn't really want to explore the option of invasive operations. You know, for those who don't know what fibroids are, they are mostly non-cancerous growths that are in the woman's reproductive system, and they can locate themselves in the muscle of the uterus area, and they can be as small as 1 centimetre, but they can grow right up to the size of a watermelon if left untreated. They could be as small as a pea, and some women don't even notice or detect that they have fibroids. For me, my concern as well is Black BME and Black and minority ethnic women are 1 to 4 times likely to have fibroids, and that statistic is on the increase, and there are a number of factors for that as well. So, you know, my role is really to work one-to-one and with groups of women to look at things that they can do in terms of their own self-care, preventative care, and work alongside the GPs to make sure that women are considering lifestyle changes as part of shrinking their fibroids, so that they don't end up having to make these very difficult decisions if they feel they have no choice around a myomectomy or a hysterectomy. There's a lot they can do before that stage if they are more informed, you know, about what creates fibroids, the environment of the womb, and what stressors and other toxins could actually increase the levels of estrogen that lead to fibroid growth. You know, so that's my area. I can't see my slides up, unfortunately. Okay, so one of my concerns, and something that I'll be publishing a book. It will be out in July. It's over 15 years of extensive research on this subject of fibroids. Has been really around the issue of a lot of GPs would suggest that women wait, you know, it's called watchful waiting, whereby if the fibroid is small and it's not causing any major threat or concern, they are advised to usually watch and wait. And you know, that's not necessarily something. I've been speaking to a lot of GPs internationally and nationally around the fact that the fibroid many times will keep growing unless certain lifestyle changes are not incorporated in a woman's life. And so months later, they only come back to the GP to then have some very difficult decisions to make about what are they going to do then. And so we're trying to work in a way that we're reaching the younger age group of women much earlier to look at some of the contributing factors, maybe some of the indicators that might point out that this person is more at risk of getting fibroids, but also working with women who already have fibroids, because I myself has shrunk mine using natural and holistic approaches. There are risk factors affecting all women, really, in terms of fibroids. And you know, as we know, they're estrogen-dependent tumours. And so, therefore, you know, it's mainly women in their 30s and 40s when estrogen levels tend to be at their heights that tend to get fibroids. But also what we're finding is more black women are getting fibroids at a much younger age, you know, sometimes as young as 20s. And my research in the book has shown that some of that is to do with hair relaxers and some of the very highly toxic chemicals that we use on our hair that actually mimic the estrogen in the body. Some of the chemicals mimic the estrogen in the body and lead to excess fibroid growth. Hereditary, obviously fibroids, if your mother or your sister have fibroids, then that could place you more at risk in developing them. Ethnicity is a factor. We're finding out that is on the increase, leading to maybe, going into 1 in 6 BME women are now finding that they have fibroids. In my study, I've been researching Black women in Suffolk area as part of my work, and there was some emerging patterns and themes in culturally, also stress and experiences of racism and discrimination. These stressors also contribute to toxicity in the body, which then leads to fibroid growth and heavy cycles and reproductive issues. Obesity is also a factor. Having a higher body mass index places women more at risk. So we look at lifestyle changes, looking at diet, in particular around lowering the sugar and the glycemic index of the diet to reduce fibroids. But stress, we can't underestimate stress, and the Black Lives Matter has really raised these issues around gross inequalities and disproportionality that are experienced by a lot of Black and minority ethnic communities. And women, statistically wise, do not spend and cannot spend often enough money on self-care, personal care. So research has shown that white women on the whole internationally spend more money on self-care in terms of therapies and alternative relaxation classes and things like that, because the reality is a lot of BME women are having to sometimes work 2 or 3 jobs to support their families and so on. And so my interest and my commitment and dedication, I spend a lot of time coaching and supporting women, working with the local, the GPs nationally, to look at how we can use resources in a way that allows women to come together in groups to learn from each other and to self-care, so that they can reduce some of these risk factors, but also reduce some of the negative experiences of heavy cycles and blood clots and pain and fibroids growing to sometimes often quite large, where women have to have invasive operations. And many who have shared in the research, they just didn't know, they didn't have the information around some of the things that they could do to make a difference. And that's my role really in supporting the local health practitioners in this way, with this body of work that I've been involved in. I could go on because, as I said, I've written a book about it. I could talk about all the, I assist women to look at all the different treatments, the interventions that are out there. I assist them in asking the right questions when they go to GPs, because they often just don't feel confident in asking questions around if they had a hysterectomy, what is the procedure, what is the risks, myomectomy, uterine arterial embolization and other treatments. But also as a holistic health practitioner, one of my things is about looking at, let's look at your diet, let's look at your exercise, let's look at your water intake, let's look at reducing the amount of red meat that we eat, let's look at non-GMO, genetically modified foods. Let's look at your vitamin content and some of the vitamins that women need to take more of in terms of their reproductive health. Let's look at some of the things that we could replace, in the diet and still have a very tasty meals. But there are some foods that are quite acidic, and that could lead to over toxicity in the body, which again can inflame and enlarge the fibroid growth. So my role is really, I work on a one-to-one or with groups to help them to come up with a personalised action plan, and we measure and celebrate the successes along the way, seeing those changes reduce symptoms and discomfort and pain, and eventually, you know, many have led to shrinking their fibroids, or in some cases, actually total elimination of their fibroids. It does take time, it does take dedication, it's not a quick fix, but that's my role, and that's the part I can play in assisting the local healthcare service. So if there's any questions, feel free to ask me.
At the moment, Imani, thank you very much for your presentation.
Thank you.
And
there was a last slide of how to contact me, if anyone managed to see that.
Okay.
If not, thank you.
We can publish that information into the Q&A box as well.
Okay, thank you for listening.
Thank you, Imani. Okay, so we have some questions that have been put into the Q&A box. So I think this is regarding the postnatal depression. So Lolu has put that there are not as many studies into postnatal depression among BAME women in the UK, but there is a suggestion that there might be unmet need in some communities because they are less likely to access mental health care. Thank you. Lolu, did you want to add anything else to that?
No, just really to encourage, I think. I mean, I can only, speaking from my experience as a GP, but also personal experience coming from a Nigerian background. Sometimes you find that, you know, mental health conditions or symptoms aren't necessarily recognized, or there might be a stigma to say, you know, I feel, you know, I'm depressed, or you know, not bonding with your baby, and you know, you sort of are expected to just get on with it. And it's really important that if you are struggling, that you feel that, and that's what, going back to what Aisha said about the 6 to 8 week check, is really important. That's one opportunity, certainly, where you have the and we almost always will ask about your mood, and just be honest and say, I'm struggling. Even it doesn't mean you go on medication or you have a label or anything attached. It's just important to talk to someone about it, and then we can offer the support that could, you know, help you get through that period. And even if it's not at the 6 to 8 week check, if it's at some other point, you know, in your you know, postnatal depression can happen, you know, anytime in the year or beyond when you've had a baby. Just, you know, feel free to speak to your health visitor about it. You ring up and speak to your GP or a clinician at your GP surgery about it. Just, it's really important that you speak to someone rather than suffer in silence.
Fantastic, thank you, Lolu. And Helen just added that in the box that the Royal College of Midwives states up to 1 in 5 women will experience mental health problems during and after pregnancy. This figure is likely to be even higher for women from ethnic minorities, reflecting the higher rates of poor mental health among BAME people overall. This is likely to be associated with factors such as poverty and low social support, experience of trauma and war, and particularly among refugee and asylum seeking women. Thank you, Helen. Okay, so there are a number of links that have been shared by Helen and Melissa, so please feel free to go on to them. And we have another question here. Is the APP and resources shared? So yes, we can, and you can use them if the panel are very happy for these to be shared widely.
So yes, so it's the app is a national app, but we've if you put your postcode in, then it brings up all the localised information around Suffolk and North East Essex, and also the Padlet. We developed it based on feedback from our community locally, but again, it can be shared as far and wide as possible. Really, it's about trying to get the message as far and wide as possible. So please do share with any friends or family.
Thank you.
Thanks.
And I have a question for our GPs. Are nurse practitioners and GPs aware that high estrogen contraceptive pills can cause problems with fibroids for women from the BAME community, and do they implement this in their prescribing?
I would say yes. We are aware that these are estrogen pills with extra estrogen as compared to what the body is already producing. And we have one-to-one conversations with the patients, what the side effects and the risk are, and it's a mutual discussion we're having. Looking at the data, and I haven't got all the data in front of me, and obviously there are lots of literature around it, but combined pills as such in the estrogen they are producing in the body do not give such a big rise to fibroids. It's not something that in my last 10 years of prescribing I have come across in BAME community that they are giving lots of fibroids as a side effect. So without looking at specific studies around it, I would say it is safe to have them as contraception from my perspective.
Thank you, Aisha. Okay, Imani, you wanted to say something?
Thank you. Yes, I just wanted to say that many BME women do go to the GP, with their complaints of very heavy cycles, very heavy periods, and have reported that, yes, contraceptive pills have often been prescribed. I mean, they do, create some sense of relief for many women. However, the moment that they stop to take those tablets, what we're finding is that the fibroid can have a tendency of accelerating its growth, and they start to grow back. So it's not a long-term fix, basically. We want to get to the root cause to address these things. But yes, they have been relieved of some symptoms in the short term.
Brilliant. Okay, thank you, Imani. Okay, and I can see that there are no further questions, and we are at our 6 o'clock. So what I wanted just to say is to thank you again to our panel, and thank you for attending. We really appreciate your participation this evening, and we hope you found the discussion useful. So just from our perspective, I will be holding an equalities webinar every month from now on. So the next one is on Tuesday, the 13th of April from 5 to 6 p.m. and you're very welcome to join again. And the topic we will be discussing is safeguarding. So we will be looking at safety for women, for children. We will be covering a whole range of issues. So thank you again for attending, and we really hope to see you next month. Take care.